it's only rare until you diagnose it. We always teach our juniors that what's common is common, but when we put here this zebra here because the zebra is chosen as a sign of rare disease. But we always say to the juniors, whenever what's common is common. So whenever you hear the hoofbeats of an animal, so it's most likely a horse, not a zebra. But we are going to present a rare disease here. For those who don't know, this is our old hospital. It was built almost 80 years ago, and it was donated by Al-Demardash Pasha, named after him. And it was the لا يجوز ان انا اتكلم ودكتور سحر هنا ما ينفعش حقيقه. Okay, it was built in the 40s and donated by Al-Demardash Pasha on the condition. But okay, okay, I didn't know this. Okay.
So this in fact confirmed what Professor Shatla has mentioned before.
Yeah, this. Okay. As my dear Professor Hamid has just mentioned, that you should take history from those who attended this. You can take science from anyone, but you take history from those who attended. So sorry for this. And this is our new hospital, new pediatric hospital that was built in 2017.
So let's start our presentation. We'll first start with our patient M. This was a 9-year-old girl, previously normal, with no significant perinatal or developmental events. She was the third in order of birth of first cousin consanguineous parents, and she has a history of SIP death at age of 4 years. Regarding her medical history, she presented firstly on September 2021 with unsteady gait. She was sleepy and incontinent, and this was in another hospital than ours. At the time, this was her MRI. It showed the multiple L-defined hyperintense signal in T2 and flare in both cerebellar and cerebral hemispheres. And she was diagnosed as acute disseminating encephalomyelitis, or ADEM. She received methylprednisolone with slow improvement. Took her about 20 days, but she was back to her normal. In fact, her second attack was in February 2022 with encephalopathy and truncal hypotonia. And this was her MRI. And as you can see, it shows acute and subacute demyelinating lesions with left frontoparietal parafalcean hematoma with laminar necrosis, and this was a new lesion. So according to this nice paper, she was diagnosed as multiphasic ADEM since she has more than 3-month attack with second ADEM episode. And again, she received methylprednisolone, but this time she didn't improve. Next month, she presented with a status epilepticus and was referred to our hospital. At this point, we used to do routine testing for COVID-19, and actually the test became positive. And we start to think, is COVID related to this hemorrhagic lesion that was confirmed with CT brain? According to this paper, acute disseminating encephalomyelitis and hemorrhagic leukoencephalitis were reported following COVID-19 infection. So whatever, we thought that this is an immune process, and we recommended starting Plex. Unfortunately, after 2 sessions, she was hemodynamically unstable, and we shifted to IVIG. Again, the patient deteriorated with no improvement. So in this part, we used to think of the differential diagnosis. We used this paper where Dr. Ming Lim had actually helped us a lot. We think of the differential diagnosis, including acquired demyelination, CNS vasculitis, anti-NAMDA encephalitis, and finally HLH or genetic versus metabolic disorders. And actually, the paper described that in presence of stroke, you usually think of vasculitis, status epilepticus, and abnormal movement would suggest anti-NAMDA encephalitis, and bilateral symmetrical lesions actually could suggest the HLH genetic or metabolic causes. But actually, our patient was not typical for any of these. So a multidisciplinary team that we are greatly thankful that included Professor Huda Tumu and Professor Khaled Abou Fatouh, Professor Shaimeh from Radiology Department, Professor Rasha Hassan from the Immunology Department, and finally Sara and me. We usually we discussed had a lot of discussion to reach a diagnosis, and this workup were all done. So her CSF analysis showed no cells with normal chemistry. MRI whole spine and orbit was normal. Anti-MOG and aquaporin were normal too. The only abnormal result was the ANA that came weakly positive. Her ANCA was normal and anti-NAMDA was also normal. So at this time, we thought of SLE vasculitis. We ordered the rest of immunological markers to diagnose lupus. And actually, Dr. Rasha was with us in this. And the decision was to take cyclophosphamide that showed very minimal improvement. So till this point in time, we feel that we have a missing puzzle. We have a patient with rapid progression, not responding to first or second line of treatment. Her anti-DNA came negative, so she didn't actually was fitting the SLE diagnosis. And remember the hemorrhagic lesion and the MRI brain. Also remember the consanguinity and the history of SIBDAN. So back to basic. I'm gonna give this lesson to our house officers and juniors. Always get back to basic when it's complicated. So we asked the family to bring the chart of her brother who died at the age of 4 years after having persistent fever, hepatosplenomegaly, and he didn't actually fit into a diagnosis, but he was prepared for BMT, and this actually raised the possibility of HLH.
So at that time, discussing the possibility of HLH, that having disease not responding to first and second line therapy, positive consanguinity, and history of sibling death. Luckily, at that time, we had a project funded by a lab, genetics lab in South Korea. It's called 3 billion. It was completely funded by that lab, and we are truly thankful to them. We had a whole exome sequencing for this patient, and it came back with this result.
And I think after the talk of Dr. Lim, you can expect what is the diagnosis. What do you think? We thought you were with us.
I'm a hematology oncologist. I'm a hematologist.
So it shows a homozygous pathogenic variant in the perforin gene, and this was suggestive of autosomal recessive HLH familial type 2.
At the time, we screened the family. She had 2 siblings, 2 female siblings. One of them was completely normal, and one was heterozygous, had heterozygous mutation. So speaking about hemophagocytic lymphohistiocytosis, what's this name, HLH? As the name implies, hemophagocytic, it's a phagocytic cell, the macrophages. It engulfs the rest of blood cells, the red cells, the platelets, and it has lymphocytes and histiocytes invading all the tissues. It's because of cytokine storm, as we see. So to understand the pathogenesis of the disease, let's understand the normal. When you have a viral infected cell, we have our immune response, the effector cells, the NK cells, and the CTLs, the cytotoxic T cells. They, after a presentation with the antigen-presenting cells, the effector cells activate the macrophages, and then the kill the viral infected cells. through a certain mechanism we'll demonstrate later. And the macrophages, after the cells are killed by the cytotoxic T cell and natural killer, the macrophages is the garbage man. They swap all the killed cells. But in case of HLH, we have this virus-infected cell. We have the effector cells. They get activated. The antigen-presenting cell present the antigen to the NK cells and the CTLs. So it gets activated. Then, but there's a deficiency in the cytotoxicity. Cells are not killed. Virus-infected cells are not killed, but we have proliferation of the CTLs, of the NK cells, and of the macrophages. All these cells secrete a lot of cytokines. Later. These cytokines, a lot of cytokines secreted by the T cells, the macrophages, and the NK cells, interleukin 2, interleukin 6, interleukin 12, and IL-10. Previous one? Yeah. Blah, blah. And this is the mechanism, just to demonstrate how this happens through the cytotoxic and T lymphocyte cells. It's called perform-mediated cytotoxicity. We have this granules through the perform that passing through a certain mechanism. It's called polarization, docking, priming, fusion, and then the perform, which is shoot to the other cell to kill the virus-infected cell. So when we have deficiency in any of these steps, we have familial HLH. Clinically, how do we diagnose this? There is some certain criteria that we diagnose it. If you have a genetic diagnosis, then it's 100% diagnosis. Clinically, we have some criteria, which include cytopenias, fevers, splenomegaly, hypertriglyceridemia, high serum ferritin, high serum soluble CD25, and some functional assays, the decreased NK cell activity or absent NK cell activity. We have the functional testing, which tests for the perforin and other mutation, other protein expression, the perforin, the CD107, this SAP and XTAP expression in the X-linked lymphoproliferative disorders. One of the manifestations in the HLH, although it's not present in the clinical criteria, but we face it a lot. We face it almost in a third of patients, maybe higher than this percent. It's the same mechanism. It's the systemic inflammation with hypercytokinemia that invades the CNS.
So it was my first patient with isolated CNS HLH, but actually while revising the reviews and articles, I found many papers that describe pediatric CNS isolated HLH. In fact, what was the thing that was striking is the shared neuroimaging. It would be very hard to describe while Professor Khaled is here. So this paper described 4 patients. As we can see, there is cerebellar lesion here, and it's reported that cerebellar edema can actually progress to hydrocephalus, multifocal white matter, high signal intensity, and T2 and flare, brainstem lesion. This also described one patient with actually spinal cord affection, and this was a question: could we have CNS HLH only with spinal cord affection? So yes, we can.
Let me say about these people. In HLH, we have only the systemic criteria. So we have almost about a third of patients, or even more than this, with CNS disease. But it's the more difficult it's that we have an isolated CNS disease. So because all the criteria to diagnose HLH are systemic, either clinical or lab, it's very difficult to diagnose an isolated CNS disease presenting with lesions like this. So
this is another paper that described even normal to non-specific findings in MRI brain with pediatric CNS HLH in 44% of their patients. So actually, we could have isolated CNS disease with very mild to non-specific findings. And here, actually, we usually rely on the genetics or whole exome. In this paper, they described, again, multifocal white matter in 37%, brainstem lesion in 9%, and cerebellitis in 10%. So here is the cerebellar lesions. I think they are very evident, and the brainstem. Another patient with actually cerebellitis that progressed to hydrocephalus. Again, cerebellitis with spinal cord affection. So if you remember, our patient had a hemorrhagic lesion that when she presented to our hospital. And in this nice book of histiocyte disorders, we found that parenchymal hemorrhage and extraaxial bleeding have been found in CNS HLH with retinal hemorrhage. They described even that this patient was first diagnosed as child abuse till the genetic came, right? This is another hemorrhagic lesion. Here, if you can see in the cerebellum, it's very similar to our patient.
So talking about treatment options, how do we treat HLH in general, and how do we treat the isolated CNS disease, HLH? So it all started back in 1996. Before this, we had almost all patients with HLH, they used to die. Then after this, after giving chemotherapy and going for hematopoietic stem cell transplant, the survival improved to almost 37.8% instead of 18.7%. So this, at that time, this clinical trial started with involving the treatment, the HLH94 protocol, including etoposide as a mainstay of therapy. Etoposide is a topoisomerase inhibitor which kills the T cells. So the main pathology of the HLH. So etoposide is a mainstay therapy. And together with dexamethasone has a good penetration to the CNS. So this why this was chosen as a kind of steroid. And cyclosporin A was given when we de-escalate the steroids. Cyclosporin A at that time was given at week 8 when we de-escalate the steroids. And it had also intrathecal methotrexate therapy for CNS diseases, patients with CNS disease, starting at week 3, not at the start of therapy. Why starting at week 3, not initially? Because they found that most patients improve with systemic therapy and did not need intrathecal methotrexate at that time. What was different after that in the HLH 2004 protocol is that cyclosporin A was started initially, and the intrathecal chemotherapy, intrathecal was not only methotrexate, but steroids as well was introduced. Until now, this protocol is a standard of care for HLH treatment until hematopoietic stem cell transplant. Let me say that hematopoietic stem cell transplant is the only known curative therapy to HLH to date. Other chemotherapeutics just hold the cytokine store, but it's not curative treatment. Other new therapies are there. Talking about the pathogenesis, we said that it's about the cytokine storm. So we have many drugs to stop this. One of them is the imapalumab, which is an interferon gamma blocking agent. It was approved actually in November 2018 for treatment of refractory HLH. Other players in this game is the JAK2 inhibitor, the ruxolitinib. As you can see here, these are the cytokines involved in HLH, and they are all mediated by the STAT pathway, JAK-STAT pathway. So the JAK inhibitor inhibits all these cytokines involved in HLH, and it's really showing good results. Other treatment options, we have some other treatment options like the anakinra, the tocilizumab, the ATG, and the alemtuzumab. Let me say that the anakinra and the tocilizumab are mainly used in the macrophage activation more than the familial HLH. And they are showing good results, but variable results. Again, the only curative therapy for those patients are the hematopoietic stem cells transplant. This publication is actually the same group that published the previous paper about the 4 patients with isolated CNS disease. For the therapy, they only gave intrathecal chemotherapy followed by hematopoietic stem cell transplant without giving any etoposide or other chemotherapeutics. And all the patients survived with good results. Yeah, it's the same. We have publications about the treatments of isolated CNS disease are not too many. So I found these 2 publications. Talking about intrathecal chemotherapy, we said that it was initially only methotrexate, then followed later by methotrexate and corticosteroids, which is the currently used treatment. Yeah, yes. Okay. Yeah. This is about the start, the timing of the intrathecal chemotherapy, and why we give it at week 3. In this paper, I showed you it put a nice algorithm about management of patients with CNS HLH. How do we manage? How do we proceed with investigations and treatment? The mainstay is the HLH 1994 protocol, or 2004. It's a etoposide and dexamethasone are the mainstay of therapy. If it's EBV associated, we give rituximab. If it's refractory disease, we give the others, which is ruxolitinib or other therapies. Yeah. So we learned the lesson from our previous patient.
So we're going to tell you that unfortunately we lost our patient M, but actually we learned a lot of lessons. We are grateful. We are very grateful to the family that gave us the trust, and we learned that rare is there. Actually, we learned to go back to basic, and we learned to work in MDT is a must. Those days you can never work alone. And this is our second patient, Kay. She's a 4-year-old girl, previously normal, now consanguineous parent. She presented with left-hand tremors, abnormal speech, and lost. Sorry, this was in October 2021. And this was her MRI. And again, she was diagnosed as infection or ADEM with these typical. But remember, here we have multifocal white matter affection and we have cerebellar affection. She was never back to normal. She has second and third attack in December and February 2022. And on in her fourth attack, she was referred to our hospital. She was cushingoid, as you see. She lost all her motor and speech abilities, and her MRI actually were progressive. Again, the same workup, but all became normal. She received methylprednisolone, IVIG, cyclophosphamide with no improvement. Here we ordered the whole exome actually earlier than our first patient. And again, it came positive for familial HLH with a compound heterozygous. Remember that this patient was of non-consanguineous parents. She was referred to my dearest friend Sara, Hematology Oncology Unit, on June 2022.
And this is her initial videos, as you can see here. So
she was right dependent and she couldn't speak or move.
So we started therapy with HLH protocol, which is based on the etoposide and dexamethasone, together with the intrathecal chemotherapy. At that time, we started, because of the very aggressive disease and very severe condition, so we started as well the ruxolitinib after consultation with St. Jude Hospital and Sick Kids Children's Hospital. So we started at a dose of 25 milligrams per meter square and adjusted the dose accordingly after that. Actually, she showed a great improvement.
I just want to confirm that we were faster this time, okay? Because we learned from our previous patients.
This was almost four months later.
Yeah,
as you can see.
Yeah.
She's showing her wig and her shoes, and she's interacting beautifully.
Sorry. So this were her MRI on June 2022. Okay. I just want to say that the radiological improvement actually took more time than the clinical improvement. After 4 months, you see that she markedly improved regarding her motor abilities, but it took us like till January 2023 to see improvement in the radiology.
These are her last videos in May, and she's planned for bone marrow transplant. Unfortunately, she doesn't have a matching sibling. Unfortunately, she has only one sibling, girl, which also came heterozygous, compound heterozygous. She had the same mutation, compound heterozygous mutation, so she needs transplant as well. But luckily, she's asymptomatic. She's almost 2 years now, but she's asymptomatic. So we're planning to transplant the older sibling. And wait, the parents are not sure about what they want to do with the younger sibling.
So finally, our take-home message that progressive demyelinating disease actually should be a red flag indicative of genetic, metabolic, or neoplastic disease. Therapy must be initiated without inappropriate delay to prevent any late effects of HLH. And finally, Sara.
Novel therapies, including anti-interferon gamma and JAK2 inhibitors, have shown promising results. However, BMT is still the only definitive treatment for HLH. And thank you.
Thank you, Dr. Maha and Dr. Sara, for this nice presentation. I will add to the importance of taking the history. In first case, I think the clue for diagnosis is the first affected child, because his clinical presentation is fitting for the diagnosis more than the neurological manifestation present.
Yeah.
Thank you.
Yes.
Any question? Okay.
Let me say that the second patient, the parents were not consanguineous. Yeah.
Actually, my question is to Dr. Khalid. Dr. Khalid, yes. Are there any clues that can help us with the radiology to differentiate if this is ADEM or this is HLH?